Yeah,
Yes.
I think we heard about all the nitty-gritty of performing primary surgery, but performing the cataract surgery, irrespective of premium or otherwise, remains even more important here. So in reference to premium IOL patient, clear cornea day one is not enough anymore now. And we struggle to get that over the years. At least I struggle. But surely it is the starting point for premium cataract surgery, because then and then you will be able to pass on the benefits of these wonderful various options of intraocular lens that we have. So make sure that surgical strategy, the performance is safe, effective, and predictable, and customized to the type of eye, to the type of cataract. You may have to change your technique or IOL option, as you will hear from others, but performance on table also will have to be changed in these premium IOL surgeries. One could be different grades of cataracts, different environment, different supporting anatomy of the eye, and so on. So I just want to remind you that the 4-quadrant technique is still a very good option, and it's a very versatile technique. So depending upon the grade, do not hesitate to perform 4-quadrant surgery. You're not an inferior surgeon by doing that. So it is a very useful technique for many kinds of cataracts. But the cataract that many of us see that needs different kind of chop techniques, and there are various modification of direct chop, stop and chop techniques, and so on. Whatever you're familiar, you need to know more than one type, because you need to combine different kind of chop action and at different times. This is an example of direct chop, as you can see, and that's very efficient in a dense cataract. But even then, you need to combine some of these different concepts. And this is one of them, that if you fail to separate, and total separation is very important in these leathery cataracts. This is one way of doing it, taking the probe out and re-impel and produce a vacuum seal at a plane closer to the bottom fibers. So you have to bury the probe twice or maybe 3 times, depending upon the cataract. And this video exemplifies that this is a pseudo exfoliation eye with a rupture and dislocated in the fellow eye, and was referred to us. So we want a minimal stress to the back. So I did initiate the crack, and now I'm going in the same plane, but a deeper plane, so that my chopper, which will be placed in the depth of the crack I initiated, will need minimal lateral separation. So that's the concept of multi-level chop technique, which you can adopt in whatever kind of chop action you have. But remember to go step by step and not aim at total division at one stroke like a karate or extreme lateral separation. One can easily initiate the crack in the periphery, but when it comes to the center, many times we end up doing so much of lateral separation. Instead, notice I went back again. I took the probe out and went into the depth, and then placing the chopper again into the depth, and I'm able to separate that more effectively with less lateral separation. So these kind of surgical techniques or concepts, and there are various techniques, and each of you have wonderful ideas about it. Make sure that it is safe, consistent, and predictable every time you perform. That was for the division, but more important now is to produce a clear cornea day one, and that's where from which plane you remove the cataract divided fragments becomes important, and lower parameters of infusion bottle height and aspiration flow rate and vacuum will allow you to work away from the cornea, closer to the posterior capsule, without fear of the rupture, because your flow rate is low, your vacuum is sufficient but not high, and your bottle height is not very high. And we reported in 2010 that doing that will produce a clearer cornea compared to the higher bottle height and higher flow rate. And now with the intraoperative OCT, we can confirm that. The video shows a very uneventful, smooth removal of that hard, dense cataract, but the OCT intraoperative is not very good. From time to time, when the lens fragment tumbles, you will notice that the fragment keeps coming in the view, and it is in the close vicinity of the fragment because I'm using a very high flow rate and a lot of vacuum. So you need to keep it away from the cornea. That fragment should never appear in OCT. This is something very useful now with the premium IOL because posterior capsule clarity and anti-capsule clarity and no fibrosis or less fibrosis is very important. Otherwise, it will defeat sometimes by decentration or producing opacification and visual obscuration. So the cortical aspiration suddenly has become very important, and I recognize the contribution of Dr. Viraj, who developed this technique a few years ago before she went out of function. So this cortical aspiration POPs technique, POPS, means positioning and all details. But the key is that at the moment, many of us, and I used to do that as a RUT, cortical aspiration, because it works out very well. I use high vacuum and flow rate, and with the radial pull, generally speaking, it works absolutely smoothly and in a very short time. But sometimes you develop PCO more and you're surprised. So this whole cortex removal has been segmented into different step-by-step steps. So first of the POPs is the positioning, the aspiration flow rate, aspiration port under the anterior cortex. First thing is to detach the anterior cortex from the anterior capsule before you go to the fornix. So you see the animation on the corner there. I'm positioning the aspiration port under the anterior cortex. And my aim is, in this whole process, is to detach the anterior cortex off the anterior capsule. So second step logically would be to place this, take this and occlude. The second take will be the occlude the aspiration port by pressing the pedal and occlude the cortex. Once that cortex gets occluded, you can use this aspiration probe as a handle and then take that as occluded aspiration port and the probe posteriorly, and you see the animation. It's very difficult to see that in the video with the 3-dimension. That once I take the port and the probe down, the anterior cortex gets detached of the anterior cortex because the epithelium on the anterior cortex, anterior capsule, has a lot of and then we swipe instead of a radial pull, and that will take the cortex off the fornix. Dr. Alan Crandall, Liliana, and others have shown that swiping movement produces less stress on the zonules compared to the radial pull, but it also removes the fornix cortex more effectively, and this is done. And once that is done, you put your paddle more on the paddle and use the preset 300, 400 vacuum that you had. So this whole process of cortex removal has been fragmented by Viraj to make it more safe, but equally important is this. And Samresh has shown this, that if you put a radial pull, if you have a radial pull like this, you can detach the cortex of the fornix, leaving behind, sometimes, not always, most of the time it works very well, and therefore we don't have much residual fibers or epithelial cells, but you can leave behind those potentially PCO-forming epithelial cells. Instead, if you go gentle and swipe, having detached the cortex from the anterior capsule, you have more chance of detaching those potential epithelial cells harbored at the fornices. So I think that's one. And finally, with the femtosecond cataract surgery in the premium IOL, I think is a deadly combination. It really eases the steps of cataract surgery. It makes it very predictable and safer in beginner's hand, experience, and everybody's. And it not only uses in difficult situations, but even in the routine cataracts and in premium IOLs. It's so nice to see this flex surgery helping us to produce that dream situation, which is in the manual things many times. So finally, keep this attitude of learning lifelong and keep the patients. You will achieve and reach there like the excellent faculties that you have here. But remember, whatever you do, premium or otherwise, patients are at the heart of all that we need. Do not recommend multifocals or toric or whatever if they really don't need, and if you think they want benefit for sake of our practice or other motives. So thank you so very much for patient hearing.